Well, good afternoon, everyone. My name is Daryl O'Sullivan, Vice President and Treasurer of Western Neuropathy Association, and I'm very pleased to welcome you to January 2024's webinar. Today's webinar will be from NEVRO, and NEVRO will be, and the gentleman doing the presentation will be talking about HFX spinal cord stimulator for diabetic neuropathy pain. Our presenter is Daniel Balcom. He is Vice President Corporate Strategy at NEVRO. His presentation will focus on NEVRO's diabetic neuropathy therapy program. This therapeutic system involves the surgical implantation of a small electronic device near the spine. The wires of the device on the spinal cord offer direct neural inhibition, blocking the passage of pain signals between the extremities and the brain. And of course, Daniel will go into this in much more detail. And at the end of the presentation, we will host questions. I'm sure you'll have plenty of them. In the meantime, please sit back and enjoy. Daniel, it's all yours.
All right. Thank you, Daryl. And thank you, the Western Neuropathy Association, for allowing us to come on today and discuss this, really groundbreaking therapy for diabetic neuropathy. And I'm going to give you some information. Please forgive me if I hit on stuff that you already understand. But I'm trying to, really trying to encompass, everything that you could possibly want to know about this. And then I'll take any questions you have at the end. So with that, let's get started. So as everyone knows in the U.S., diabetes is one of the most common diseases out there, and one of the consequences of it is diabetes-related neuropathy. And so, if you think about the 37 million or so patients with diabetes in the country, a quarter of that population at some point will experience pain from diabetes-related neuropathy, and then some portion of that will try medications that will fail, and unfortunately will be left with just a disease process that until now really have not been a lot of, or maybe no options for the relief that you deserve. So diabetic neuropathy, it's the most common complication of diabetes in the US. And again, I'm probably telling you stuff that but it's nerve damage from diabetes and high blood sugars. And it can happen, from any time along the span from the time that you're diagnosed with diabetes, 5, 10 years later, 15 years later. And some of the more common treatments out there are medications like gabapentin, pregabalin, tramadol, combining those medications, trying different doses, different strengths. Some people have tried capsaicin, which is a topical ointment on the feet. Obviously health behavior changes, exercises, dietary, all these things are tried, but the most common are the medications out there. And as we all know, there's really not a medication out there that does not have some sort of side effects. And unfortunately, the Lyricas and the gabapentins have a whole host of side effects that a lot of patients find, they may get relief using the medication from the burning in their feet, but the consequences, the side effects are a lot of times too great. They outweigh the benefit. And, you see, short-term memory loss, and your brain's dizzy and foggy, fatigue, weight gain, weight loss, nightmares, just a lot of stuff that you obviously don't want to deal with, and unfortunately wind up being worse than what you're dealing with to begin with just the pain from the diabetic neuropathy. And then we have the worst of all, which is, some patients wind up being prescribed opioids. And these are some staggering statistics around opioids. It's, 1 in 3 patients are abusing or misusing their opioid prescription. And, it's kind of like, yeah, that's obvious, because opioids are one of the most addictive medications on the planet. So of course, yeah, people that are on long-term opioids are going to, and no consequence or no fault of their own, are going to wind up abusing or misusing them because they are so terribly addicted. Another stat that is staggering, and this is straight from the CDC, 1 in 500 patients that are on long-term opioid treatment will die in a given year. So 1 in 500 patients. If you think about like what out there kills 1 in 500 people a year, like one of the most dangerous sports you can participate in is free dive spearfishing. So you take a big gulp of air on the surface with your spear gun and you swim down into shark infested waters and you shoot a fish and you try to make it back to the surface without running out of breath or getting eaten by a shark. The death rate in that hobby or sport is about 1 in 500. So patients that are on long-term opioids, it's akin to jumping in the water without a scuba tank on and swimming down and trying to get a fish before a shark does. So that's a pretty, obviously there's got to be better options out there, right? Well, fortunately there is. So about 2.5 years ago, NEVRO received clearance from the FDA to market the spinal cord stimulation device that we have and only we have for the pain from diabetic neuropathy. And so obviously the big question for anyone that doesn't know is like, all right, well, tell me about spinal cord stimulation. Like what is spinal cord stimulation? Well, on its base level, it's a method to treat pain without the addicting qualities of the painkillers that we just talked about. So it is basically, it is a not a complication free, but it's a side effect free device. It targets the nerves that cause your pain, and that does that by sending electrical impulses that really trick your brain initially into you don't feel those pain signals. And then we have some evidence that there's some rewiring of those pain signals going to your brain. So your spinal cord, there's a healing that takes place in the spinal cord and in the brain as well. So the good news is spinal cord stimulation has been around for a long time, and it's a in the realm of any type implanted device, it's a really safe procedure. Like I said, relative to all implanted devices. I mean, anything that you implant, any surgery that you undergo, obviously there are risks involved with that. But in this grand scheme of things, and relative to all other devices, it's a very, very safe device. It's been around for over 50 years. 34,000 patients a year are implanted worldwide with the device. It's it consists of 2 thin wires that, as Daryl said earlier at the very beginning, are placed near the spinal cord, and then they go to a little pacemaker-sized battery that you have full control of from an app on your phone from the outside. The great thing about it is it's one of the very few treatments out there that you get to try before you have to make a decision. So you can go through a very short 7-day trial period with this device externalized, and it's basically like an epidural for labor and delivery. And they place two thin wires like that. You go home with the device. You come back and you tell them, yeah, it worked, or no, it didn't, and the device comes out and you're no worse for wear. So it's one of the few devices, like I said, that you don't get to try out a knee or a hip implant or a pacemaker or anything like that. But this is one of those devices that you do get to try it before you have to make a decision. So the reason why you may have never heard of spinal cord stimulation for diabetic neuropathy, or you've known friends of yours or family members that have had this device for diabetic neuropathy, or maybe yourself, and it didn't work, or it didn't work really well, is because up until now, the devices on the market were a lower frequency. So they actually induced a tingling sensation that masks the pain. And the last thing that someone wants that has diabetic neuropathy and their feet are already tingling and it's painful is more tingling. So a lot of times you saw those devices worked initially and then they stopped working later on. But that's, like I said, those are the older style devices. The NEVRO 10 kilohertz therapy, the one that the FDA approved for diabetic neuropathy, works on a different pathway. And I'll show you some of the results here in a second. So we did a large randomized controlled trial, and you have to do these large controlled trials, and they consist of, in this situation, was almost 200 patients. It's heavy oversight by the FDA, because when you do an RCT like this, you're petitioning the FDA to say, hey, we believe that this device is going to work for X, and we're going to partner with you, and you're going to help us design this study, and you're going to have oversight on it. And at the end, we want, if it works, we want, your approval to go out and market this to the patients like yourself. And so they're heavily involved with the study. We had really great results. We published at 3 different intervals. So at 6 months, at 12 months, and at 24 months in JAMA Neurology, Diabetes Care, and Diabetes Research and Clinical Practice. And the results, for the base thing that we were looking for, we were mainly focused on pain control. If we can get these patients' feet to stop burning so they can get back to a better quality of life, that's the number one thing we wanted to do. And we saw great results from that. So if you look at this chart, it represents, patients during the study coming in and being asked, you guys have all seen this, what is your pain on a scale from 0 to 10? So all the patients in the study at the baseline, which you see to the far left, were asked, and this is an average of all those 200 patients I was talking about. So at baseline, this group, their baseline pain level was a 7.6, 7.5 area, which, if you think about that scale, when they give it to you, like 0 is no pain, 10 is the worst pain imaginable. Boy, this patient population is really up close to the worst pain imaginable when they first came in. After implantation took place, that pain quickly dropped down to that 2.8 and 2.4 range. And the reason why you see 2 lines here is because we had 2 sets of patients in the study, one that received treatment immediately. The other patient continued with their conservative medical management. So whatever pills they were taking, they stayed on that. And then at 6 months, this patient population that wasn't offered the stimulator to begin with had the option to cross over, to say, hey, this medication is not working, I want to try the spinal cord stimulator. Almost 100% of those patients crossed over, but that's why you see those 2 lines. One is the group that was implanted initially, the other is the crossover group. What's nice about this is both of these groups fell to roughly the same exact average pain scores. The other thing to take away from this slide is, like I was saying earlier, a lot of the older stimulators, and I say older, I mean, they're still on the market now. I mean, old technology. One of the consequences of it is you'd see this line drop off and patients would do well and be like, wow, I feel great. And then 6 months later, that pain would start to creep back in. And pretty soon they were back up, not too far off of where they were to begin with. The nice thing about this study and what we're seeing in clinical practice with patients that we're working with, patients that Amanda, who's on the call, and she's a local rep there in the Phoenix market, what she sees every day are these patients, getting better and staying better. And so going from a 7.5 down to like a 1.4, 1.7, I just turned 50 this year. I feel like I wake up, or I feel like every day I'm at like a 1.4 or 1.5. It's, obviously not ideal. I felt much better when I'm in my 20s, but 1.4 isn't bad. I'm not, impeded from, being with my family or work or anything like that, versus being at a 7.5. That's, obviously terribly disruptive to your life. And guess what? The other thing we looked at is sleep disturbance, because, as everyone knows, like if you don't get good sleep, I'll put it the other way. I feel like I can conquer the world with a good night's sleep. Without that, it's going to be a struggle. If I'm in pain at night, and a lot of neuropathies, unfortunately, are worse at night, you just don't sleep. So this was another great indicator of how well these patients were doing. That was enough alone for the FDA to say, yeah, this treatment is working really well. Absolutely. We'll give you this indication. You can go out and publicly claim that this device works well for patients with diabetic neuropathy. Another thing that we looked at in the study was what kind of effect did this have on the patient's neurological symptoms? So if you just think about, like, if you have neuropathy, if you're on this call and you have neuropathy right now, I'd be willing to bet you currently are feeling one of these problems, or possibly all of them, or you have at some point in dealing with this, with this terrible disease: numbness, tingling, burning, cold, all those symptoms. So what this slide represents on the left is, well, let me tell you this first. So all the patients, when they came into the study, they were given an iPad by the clinical research coordinator. And the research coordinator would ask them, say, all right, here are these diagrams to represent your feet and legs. And you have numbness, tingling, burning, and cold. Shade in where you feel each of these symptoms. And what you see on the left is an average at baseline, so before anybody was implanted with any device, of where the patients were experiencing these symptoms. We looked at the changes. So we gave the patients an iPad when they came back in at 1 month, at 3 months, at 6 months, 12 months, 18, and 24. And what we saw was a gradual improvement all along the way, with the maximum effect out at 2 years. So you can see at the bottom, cold almost completely went away. Burning, tingling, same thing. What we did not expect, and was probably one of the things that, we've dug into the most to try to understand the most, is the numbness. So how in the world were patients that were coming into the study, as you can see on the left, saying the entire bottom of my foot is numb? How at 6 and 12 and 18 and 24 months are they coming back and saying, like, hey, I feel the bottom of my foot again? And Amanda can give you anecdote after anecdote from the patients that she's worked with, but we have patients all the time that come in and say, hey, I stepped on something in the living room last night, a Lego or whatever, and actually felt it, and I haven't felt the bottom of my foot in years. We have patients that have gone back to work because, in particular, this one guy that was a contractor and needed to get up on ladders. He couldn't feel the rungs of the ladder, had fallen multiple times. He gets some feeling back in his feet. He can feel the rungs of the ladder again. So we saw this in the study, and then as patients were getting implanted, we're hearing these stories. This kind of compelled this, Dr. Jeffrey Chin. He's at the University of California, San Diego Medical Center, a really well-known researcher in the pain world. But, he was, obviously paying a lot of attention for the study. He began to use the device in his clinical practice. He started seeing this. He is wondering, like all of us, like, what is going on physiologically with this patient population? They're coming back in and saying, I can feel the bottom of my feet. Well, like, what's really going on? So he recreated our study in a small group of his patients. It's only 6 patients, which is, it needs to be studied further, but it's still a really good signal. So with the patients that he enrolled in the study, the 6 of them, he did a punch biopsy, which is, you take a very hollow needle. It's not painless, but it's not terrible. And they take a small tissue sample from the patient's feet that were in the study. And he looked at those tissue samples at baseline, so before any treatment was applied. And then he looked at those samples every 2 months, all the way out to a year. And as this patient population, just like what we see, like what I've been saying, are saying, like, yeah, the sensations coming back in my feet. As he's seeing this, he's looking at these punch biopsies under a microscope, and he's seeing an increase of nerve fiber density. So the nerves that had died off because of diabetes and neuropathy were starting to grow back, and he is physically seeing that happen as he's taking these punch biopsies along the way under the microscope. So, the mystery has been revealed of, like, yeah, patients are telling us the numbness is going away and their nerve fibers are growing back. Not the only, but one of the questions that remains is, Why is that happening? And that's something that we're trying to figure out, but we haven't yet. I mean, right now we're just super happy that it is happening, but we are, we're putting in efforts to figure out why that's happening. So with all of this that's going on, all this good news, all this stuff coming out in the papers, the anecdotes that are coming out, one of the most proud things that we've had happen in relation to this is, two of the most respected endocrine societies in the world, the American Diabetes Association and the American Association of Clinical Endocrinology, wrote 10 kilohertz therapy, so NEVRO's patented waveform, into their treatment guidelines. So, and these are for physicians. So if you're a physician and you are, you have treatment guidelines. So if you're a physician, you're obviously not just out there flopping in the breeze, making your own decisions on everything. Your society that you work with and you're a member of publishes, like, if you treat patients with diabetes, you need to do this, and if this doesn't work, you need to do this, and it's a whole algorithm. Well, they wrote into the algorithm, if you have patients that have painful diabetic neuropathy, and like we talked about, it really painful, the medication's not working, NEVRO high frequency spinal cord stimulation should be a consideration, should be something that you offer the patient and educate the patient on as an option. So that was a huge, those both were huge accomplishments for the space. It's great because it gives your doctors confidence to offer this therapy to you. It's good for us because we got to see, we spent a lot of time and effort on creating this clinical data, and it's good to see it recognized by these two prestigious societies. So with all that being said, it really comes down to, I'm sure what a lot of, anyone that's suffering with diabetic neuropathy on this call, or anyone that has a family member or a dear friend, it's like, all right, well, who is a candidate for this therapy? And fortunately, it's a really simple formula. It's exactly the protocol that we looked at in the study. It's exactly what the ADA and ACE are recommending. It's first, are you diagnosed with diabetes? Yes. Have you been told that the neuropathy that you're feeling in your feet, the burning, the numbness, the pain, the chills, all that, is related to diabetes? Yes. Have you tried conservative measures first? So have you tried medications and either they didn't work to resolve the symptoms, or the complications, the side effects from the medications just weren't worth it? Those were worse than the pain you're experiencing from neuropathy. So if we've tried all that and you still suffer from pain in your feet and legs, the last thing is to make sure that your A1C is somewhat controlled, because obviously the higher your A1C and the higher your blood sugar is, the more of a surgical risk you are, or more at risk you are in surgery. So as long as those are checked, then it's worth having a conversation with your physician about this as a potential treatment option. So I'm going to hit the trial in a little bit more detail, because I think this is one of the most unique things about this therapy. So the trial, like I was saying earlier, so there's a trial implantation period where the physician is looking at your spine using X-ray. They place 2 wires, just like anybody who's ever had a baby or had, husbands out there that have seen their wives, like I did, have an epidural for labor and delivery. It's a small needle. They place a thin catheter. This procedure is almost identical to that. The difference is those catheters stay in for a period of about 5 to 7 days. So the physician will pull the needles out, or the cannula out, and they'll tape over, as you can see on the right side of the screen, the wires, and this little puck that is there is taped down to your skin, and that's what sends the pulses. And you have full control over that system. Like Amanda is, if you're in Phoenix and you're working with a physician that Amanda works with, Amanda will call you every day to make sure that you're doing all right and make sure that the therapy's tuned in. And then the greatest part about it is you get to come back at the 5 or 7 day mark, whatever your physician decides is the best for you. and sit down with the physician. Someone like Amanda from our team will be there, and you get to discuss, like, and they'll ask questions like, do you feel like you got a significant amount of pain relief from this? Yeah. What do you, how much do you think it was? Was it 50% or was it 100%? And you get to tell them, like, it was, 70 or 80%. Do you have any, complications that would, make you not want to move forward with this device? Yes or no? Your spouse, a lot of time, or a friend of yours that is there, and they give feedback like, oh yeah, Bill was like getting around like I haven't seen him getting around in, a decade. We'll take all that feedback, and then it's all your decision. The doctor will tell you, like, hey, personally, I feel like from your results from this trial, this is a good therapy that you ought to pursue. And then you get to make that decision. Like, yeah, I think so. I totally agree. And then you'll come back, and there'll be two small incisions. They'll kind of do this procedure again, and then you'll have a battery, a little small IPG, just like a pacemaker type device, implanted kind of on your hip. You have full control over it from the outside. It's rechargeable. It lasts 10 plus years. And that's how the therapy works. And again, our reps are constantly in contact with the patient. So if you ever have something's not working right with the device, you need it fine-tuned, your pain's coming back, these guys will meet you there in your doctor's office to make sure you're taken care of. And they're also there for, questions you have all along the way, from start to finish. So last slide, or next to last slide, is it's kind of like if you've heard this presentation, you're suffering with diabetic neuropathy, like what are the next steps? Well, we have a really good website, hfxforpdn.com, that I'll make sure that Daryl and the team make sure that you guys all get this, so you don't have to take a picture of the screen or write it down if you don't want to. But if you go to hfxforpdn.com, there are a lot of different resources on that site. There's a find a doctor thing, so you can look up your zip code and see, find physicians in your area. You can also take this questionnaire. So all the questions that we were talking about, do you have diabetes? Is your pain greater than 5? All those questions, it kind of goes through that. And then it'll get you in touch with someone from NEVRO that, if you don't want to just reach out to the doctors blindly, from the find a doctor thing, they can help get you in touch with a physician in your area. And hopefully get you the treatment that you need and deserve. With that, I'm going to hit this last slide. So just, like with anything with medical device, pharmaceuticals, or anything, there's, just make sure you understand the risk around it, and your physician will have a conversation with you about that. But again, you can go and look at nevro.com manuals to understand the prescribing information, indications for use, contraindications, and warnings and precautions. I won't go through all that today, but like I said in the beginning, this, in the realm of implanted devices like pacemakers and all that stuff, it is a safe procedure. And with that, I'll turn it over to some questions. And Daryl, I think you said you're going to run those.
Thank you. Excellent presentation. Thank you very much.
Yeah,
so we're going to go on to some question and answers. So I'll start off here and sort of read the questions that some of the participants have put through. First one says that my MD said she would not recommend SCS because of no procedures, injections, ablations. I didn't quite understand the question, but maybe you'll understand it.
Yes, sir, I do. Yeah. So spinal cord stimulation, like I said, has been around for a long time. And historically, it has been used exclusively for back and leg pain from, like, if you had a spine surgery that, everything was fixed mechanically, but you still have a lot of burning pain and that sort of thing. That was kind of our typical patient before this diabetic neuropathy indication. With that patient population, when you're dealing with this like spine pain, physicians do want to make sure there are a lot more tools in the toolbox. If you have that going on, there are injections and ablations, which is burning just sensory nerves that they're causing pain, but they don't have any other function. So that may be what your physician is talking about. There's really not a whole lot. If you have just pure diabetic neuropathy, there aren't, like I said, I mean, it's really medications and then capsaicin treatment, which is like a hot sauce kind of thing on your feet that works for some patients. But outside of that, there's really nothing else.
Okay, so
Hopefully
the
that
next
answers your
one,
question, Lauren.
the next is more like a comment. Worked for me. Is that true? Question mark. So I don't know what
Um,
that means.
work
Anyway,
for
let's
me.
go on to the next one. Um,
Okay.
how will your spinal cord stimulator work on peripheral neuropathy symptoms not caused by diabetes?
Yep. So that is one of those things where we know that like patients are trialed and implanted for idiopathic, which means like unknown neuropathy. So neuropathy that you really don't have, you can't say yes, it was caused by diabetes. I know that patients have been treated with that. I can't stand here and claim like how well it works or if it doesn't work or anything like that, because we've not intently studied that and gone through that rigorous process with the FDA like we did with diabetic neuropathy. So I would tell you, like, I would have Catherine, I would have that conversation with your physician, and you can still go to hfxforpdn.com and find a physician, and just have that conversation, and you guys make that decision between the two of you.
Okay. Next one is actually the same. So we've already answered that. And the next one is, do you have to wear the device essentially forever?
So the device is completely implanted inside your body. So there's nothing sticking out. There's no, you could feel, a little lump under the skin, on your hip where it's implanted. Other than that, there's nothing on the well, there's nothing on the outside. But other than that, you really don't know it's there. The device is rechargeable, which is a great thing because that allows this device to last 10 or more years. So the recharging is, our patients charge on a schedule. From some people like to charge every day because they watch, some TV show at night, and they're like, all right, I'm going to charge for 5 or 10 minutes while I'm watching. And that just involves placing the little thin disc on your skin, right over the device where it's implanted, and it just charges through your skin, just a radio frequency pulse. You don't feel it. There's no heating up or anything like that. And that charges, and then you have, some patients charge once a week, some patients charge once a day, some patients charge every 2 weeks or 3 weeks. It just depends on how much power you're using and how you want that to fit into your lifestyle. The device runs off of you control it with your iPhone. So there's no, I mean, it's the same phone that you're using now. And, as far as forever goes, that's another thing that's really is unique about this device is, say that, the device was implanted and, it worked for 3 or 4 years, and then, you turn it off one day and your pain never came back, and you have it for 2 or 3 more years, and you're like, you know what, I don't have this pain anymore. I just want this device out, or the other side, say it didn't work, and that happens for, our study says for 9 out of 10 patients it does work, but say, unfortunately you're that 1 out of 10 that it doesn't work for. And I just want it out. In either of those cases, the device can be removed. All that you have to do is you make an incision, right where you made the other one. It all comes out, and you're no worse for wear other than you've had to undergo this minor surgery. So it's not like going to spine surgery or something like that, where there's any, something destructive done and changing your body or anything. It's you kind of go back to where you were. You have a small scar there, but you're no worse for wear. Hopefully that
Okay.
answers your question.
Well, let me sort of add on to that. So the wires are implanted under the skin,
Yes, sir.
and the actual the actual battery is in the little puck, or whatever you want to call it. And is it in the front or the back of your hip?
It's they implant it in two places most commonly. One, so there'll be a small incision. So if you feel around onto your back and you feel where your pants, where your waistline is, if you feel up about 2 or 3 or 4 inches, you'd have a small incision there, up like an up and down incision, and then that would be where the wires go in, and then they go under the skin over to another little small incision just to the right or left of that. That's one way that it's done. The other is same small incision in the midline, and then one just below your belt line, off to the right or the left side on the back.
And what's the average time to recharge?
If you are somebody that, and this can be influenced by some patients' power requirements are greater than the others. So I'm just going to give just like a huge average. But if you recharge every day, your recharge times is like 10 minutes or less. If you wait a week or so, like it fully depleted, if that takes, you're a patient that takes 3 or 4 days, or it takes 2 weeks, that recharge time is like 45 minutes to an hour.
Okay.
But you're not immobile when that's happening. I mean, you can tuck that in your pocket and have that puck over and walk around the house or whatever.
Well, it sounds like the phone will tell you when you need to be recharging besides.
Yeah. You don't have to worry about that.
Yeah. Okay, let's go on to another set of questions here. Are you going to try this on another type of peripheral neuropathy like chemotherapy-induced peripheral neuropathy? It's sort of like the same question before, but this is a more specific problem relating to peripheral neuropathy.
This is a great question. So we're super interested in understanding the effect on chemo-induced neuropathy. Absolutely. And so I can't give you a timeline, but I can tell you that our scientific team is highly interested in this because, it kind of falls in the same realm that diabetic neuropathy does. It's just there's not a whole lot out there that can treat it. And, it's just it's a terrible disease. I mean, it's such a tragic disease where you survive chemotherapy and you survive cancer, which is wonderful and great, but you're left with this horrible burning neuropathy. And it's something that it really pulls at the heartstrings of people in our organization. And there's a huge unmet need out there. So I would expect to see something coming down, some data around it coming down the line. But kind of think back to the same question of earlier. I mean, it's worth going and have a conversation with a pain physician right now, because they may choose to do that procedure off label if they've seen it work in their own hands. So yeah, it's a conversation with your physician.
Now, is NEVRO probably thinking of multiple clinical trials?
So you
based
mean
on the kind of peripheral neuropathy?
So yeah, exactly. So in order for me to be able to come on a presentation like this, or us to advertise in the field around like it works for X, we would have to do a study on it. And just like we did with diabetic neuropathy. Now, I can tell you, like, again, back to the question on kind of the general neuropathy, physicians are doing trials and implants for patients that show up with chemo-induced neuropathy and peripheral neuropathy of whatever, type. And, anecdotally, I've seen patients do well with it, but I can't sit here and tell you like I can with diabetic neuropathy, like it's going to work 9 times out of 10.
Yeah.
But I guess
the data.
I don't know if it's a good time to introduce myself, but I thought that was a really good point to my name is Amanda, and I've been on the call too here with Daniel. I work I've worked for NEVRO for a little over a year, but I've worked with NEVRO as an RN, registered nurse in surgery for 8 years. And I chose to come on with NEVRO to be a part of their team because of the impact that I saw with the patients. But I unfortunately didn't get to see them after that day. So I wanted more of a follow-up and a role in, what they were doing. So, like Daniel was saying, we would not be able to come on here and say that something, this device is intended to work for, that we don't have that approval. But do we hear testaments? Did I just see a patient today with something of that type of neuropathy that this is helping? And sometimes even, those things are discovered, obviously, with this neuropathy indication being we were originally targeting low back pain and leg pain and things, and started noticing these improvements. So as our eyes are opening to all this and we are running these studies, we're taking all that into account, and definitely loving to hear the testimonies from patients that is also working for that type of neuropathy.
Okay, so let me give you another question here. So if I already have a spinal cord stimulator for back pain, can I also have the NEVRO system for peripheral neuropathy?
So
For
more than
diabetic
likely-
peripheral neuropathy, yes.
So it depends on several factors. If that stimulator is working really well for your back pain, that the physician is going to be reluctant to change anything with that. Depending on where and how the implant is taking place, they may choose to add this system to that. That's typically not what we see. A lot of times what we see is the physician's like, hey, I think I can get your back pain and your peripheral neuropathy we just swap out the system. But because I don't know anything about your condition, so it's super hard for me, like what's going on, how your device was implanted, where it was implanted. So it's super hard for me to answer that question. The best answer I can give you is that's worth a really good conversation with your physician.
Yeah. Okay, the next one is, are there weight and height limits, or are these factors that would need to be considered for implantation or signaling?
No, there's really no weight or height limit that's imposed by the device.
So the next one would be, are there any conditions or devices that are indicated for NEVRO's SCS?
So contraindications are, diathermy, which is a therapeutic heating procedure that's used for deep tissue heating, is a contraindication, which is, just not used a ton, but that could potentially cause heating with the device. These devices used to have a contraindication against having an MRI. That's not the case anymore. So this is MRI compatible if you ever needed an MRI. Outside of that, there really aren't any contraindications around the device.
Okay. Yeah, the next question I have is, have you seen any improvements in autonomic symptoms, or only the sensory type symptoms and pain?
So we've only really seen and studied the sensory type symptoms. And so if you think about pain, is really kind of roughly categorized into two taxonomies. One is a nociceptive type pain, which is if you have arthritis and you don't have any joint left in your knee and your bones just grinding on each other, that's a nociceptive type pain. And spinal cord stimulation, no matter what device it is, doesn't typically work on that. It does work really well on neuropathic pain. And so that's why with our back pain patients that we work with that I mentioned earlier, like the structural problem was fixed, the fusion took place or whatever, but there's nerve damage causing neuropathic pain. It works really well for that, as obviously for, works well for neuropathy too.
Okay.
Hopefully that answered your question.
I'll say the next one is it covered by insurance? And I think the rest of it is all insurance.
Yeah, so it is covered by, so Medicare, is broken down into, so there's the overarching Medicare, and then you have the Medicare administrative, it's called Max, but anyway, like Novitas is California, or Novitas is Texas, and First Coast is Florida, and Meridian's California. All of the Max for Medicare approve spinal cord stimulation for diabetic neuropathy. And right now we're up to about 75 or 80% of all commercial insurances approve it. I can't remember off the top of my head the one or two that don't, but it's not many.
But Medicare and Medicaid do.
Depends on what state you are for Medicaid, because Medicaid is
Okay.
kind of a hodgepodge.
Okay.
I'm not sure how it is in Arizona, but yeah, that would be a conversation with your physician. But yeah, definitely Medicare, 100%.
Good. I think that answers most of the question there. So interesting to hear that the SCS may influence regrowth of nerves. This could possibly be a cure for any type of neuropathy. That's a comment more than it is a question.
Yeah, I'll comment on that. So we absolutely hope so. And what we'd love to figure out first is why we're seeing that, why are patients coming back in and saying, like, hey, this numbness has gone away? Why did Dr. Chen see regrowth when he looked at, nerve fibers under the microscope? We'd love to know why that is happening. And then ultimately, yeah, I totally agree with you. Like, I'd love to know if this works for diabetic neuropathy, does it work for, for all other types of neuropathy that you wind up with numbness and all the issues that arise from having numb feet or numb hands? We'd love to know the answer to that.
Yeah, no, I think that's a very good question. I'm only going to know long term until time goes by and we have a lot more research. Okay, that actually covers all the questions that we have. I want to thank you. First of all, any other comment you want to make
Sorry,
concerning
Daryl,
this?
I just wanted to raise my hand. I saw one pop up about NEVRO being different, and I just
I
wanted
see
to
some more now. Okay.
Yeah.
Sorry,
So,
thank you.
Yeah.
So,
Yeah.
How is NEVRO different from Abbott's SCS?
Yeah, so NEVRO is, so we have a patent on 10 kilohertz frequency and stimulation. And so Abbott's frequency that they work, so there are a couple other companies out there that have SCS devices. Abbott and Medtronic and Boston Scientific are all other devices in the space. All of those companies, by restriction of our patent, are limited to a frequency range of in like 100 or less or 200 or less. And those frequencies work on a different mechanism of action. So they work in a different way. So what I was describing earlier, where, I said, the older type stimulator devices, the older technology, which is this low frequency, those work on a pathway that causes it's called paresthesia, but it's basically, with those devices, you have to create tingling in the areas where you have pain. And so that obviously doesn't work real well typically on neuropathy, because the last thing that patients with tingling and burning in their feet want is more tingling in their feet. So that is the main difference between NEVRO's device and Abbott's and Medtronic's and Boston Scientific. And again, we have the patent for that. And that's, so, when you saw earlier in the presentation about 10 kilohertz, that's, specifically was called out by the ADA and by the American Association of Clinical Endocrinology, 10 kilohertz specifically. And they called that out because that's what all the data has been collected around 10 kilohertz. And that's where you see, patients, 9 out of 10 patients doing well with this therapy, where you didn't see that historically with the other devices.
Okay. Here's another, actually, I think there will need to be investigations into neurotransmitter expression and the expression of tissue growth factor like insulin growth factor under the influence of this device.
So I'm going to need to get Glenn in touch with somebody that has a more science background than I have. But great question, Glenn.
And well, Glenn's pretty sharp at all this, I can tell you that for sure.
Yeah.
But I think he's quite right in terms of it. There
sure.
are.
So I will comment on that, Glenn. So I actually had a call with one of our chief scientists day before yesterday, and we were talking about some of these things. So his job, so we have an animal lab where we're trying to understand this, and his name is Kerry Bradley, and he is actively trying to understand, when we're applying stimulation, are we seeing these growth factors that are driving this this nerve fiber density growth, or is it the fact that we're so another thing we saw in the study, and this will be published pretty soon, so I didn't put it in the slide deck because it's not published yet, but we saw a weight loss and A1C reduction in this patient population that we were studying out to 24 months. So is it, patients just are getting healthier because their feet aren't burning like crazy and they can actually move around, and that's what's driving some of this? Or is it some of the A1C reduction? Or is it a combination of all of those things? But those are the things we are actively trying to understand for sure.
Yeah, I think that actually adds to the next one as well. So certain possibilities for investigation into the IENF, regrowth, which I think that really covers most of that.
Yep.
So here's the next one is, can you have any MRI with the SCS?
Yes, you can have an MRI with SCS, and there are some restrictions with that. So it's nothing that would impact you. I mean, it's just the way the machine needs to be set up so that the technologist will adhere to those, and they have the same type restrictions with just about any implanted device, so they're used to it. But yeah, the short answer is yes. If you need an MRI, you can have an MRI.
Lindsay, do you see any other comments or questions that we need to address?
You guys got them all. I think that's
Pardon?
it.
Okay, I think that's all I can see at this point. So again, if you want to make a summary, please do. That would be fine with us. If not, we'll just go ahead and say thank you very much for an excellent presentation and also for the nice exchange of information relative to the questions. Appreciate it very much.
Yeah, absolutely.
Absolutely. I did want to say really quick, just again, just being a part of it and letting you guys know kind of because Daniel speaks so well on everything with the company and device related. Just being a field member of the team, I'm in Phoenix, located in Phoenix, but we have teams all across the country. So again, I know this is a support group and we want to be here to support you. So just know that there is teams and resources all over. You're not, in an area that can't be serviced. And when you do meet with your NEVRO team, those are people that are constantly in communication with you. Like Daniel said, through the trial, you build a relationship with someone for a week that you consistently talk to each day, and they get to know your pain patterns. They know that you want to walk your dog just down the block, and that's your main goal so far. And then they work with you to get to that goal, and then it may be further, but you have teammates assigned to you within your local territory, that it's not something that you don't get to have an in-person interaction in your doctor's office with a member of our team that can help. We're partners with your doctors, really, just to help you get the best relief for something that you've been struggling with for a while. So just kind of wanted to add that factor. And myself, I'm a nurse. A lot of my teammates on the team are nurses, and there's 5 of us under my manager, and we have multiple teams even just within Phoenix. So there's resources and people, around to reach out to as well.
So one last comment is, how could we get and find more information?
So Daryl, we'll make sure that you have the link for hfxforpdn.com to send out to the group. But that would be your first resource. And if you go there, there's a, like I mentioned, there's that questionnaire there that would trigger someone live to call you. You can also, there's a physician finder on there if you just want to go directly like that. And there are quite a few other resources to read into on that website.
So I think you already covered this, but does Medicare cover this if you, something I can't understand the diabetes part of it. If you have pre-diabetes, I think.
Yeah, so I would have a conversation with your physician and about around that. I think you're going to find out, yes, that you can, because the physicians are going to, if they believe it's going to work for you, they will work with the payer to figure out how to get it paid for. That one's a little bit more, of a question mark, but again, it's worth having a conversation with your physician for sure.
Yeah, okay, sounds good. All right. Well, again, thank you very much. We really appreciate it. And the another one, let's see here. Okay, I think I got, nope. I just wanted to make sure I didn't miss one. So we'll have this recorded. It'll be on our website for our members and others to view. And we, again, appreciate very much your time and effort. And thank you very much.
Yeah, absolutely. And thank you guys. We really, really appreciate the opportunity to speak to you. And I love the questions and this engagement. I wish I could see all of your faces, but maybe next time. But anyway, thank you, Daryl. Thank you, Lindsay.
Thank you.
Thank you
Take
so
care.
much for your time, everybody.
Thank
Take
you
care.
guys.
Bye-bye.
Have a good
Thank
day.
you.
Thank you.
Bye-bye.
All right. Take care.
Bye.